Good morning, everyone. Again, same situation as yesterday. Unfortunately, Hillary couldn't be here because she had to leave the conference early. She sends her regrets, but I'm excited to present our research from the last conference on her behalf. So I know yesterday I presented a lot of the more metabolic and genetic stuff that Hillary did, so I'll kind of intertwine that into this presentation for those of you who weren't present yesterday, but I'll also go into more detail about the strength and physical activity information that I collected from the clinic that you guys so kindly gave up your time to participate in at the last conference. So again, just want to talk about more details about the 6-minute walk test results that we saw, the strength that we saw, and then those physical activity questionnaires that you guys also so kindly completed for me. Again, Dr. Vernon, with that study, was looking at the specific genotype information that you guys provided, as well as cardiolipin ratios. You guys remember Dr. Thompson was doing the echocardiograms. You guys all know Becky very well. Jessica Rubens helped Dr. Vernon with some of her lab work. Frederick Vaz helped with our cardiolipin analysis in Amsterdam. And then Dimitri was so kind to do all of our statistics for us. So total of our participants, you guys were awesome last year. We had a total of 42. I personally saw 34 of you guys. Again, Dr. Thompson did the echocardiograms. You guys remember I assessed the strength 2 different ways with that dynamometer that gives us an actual force in pounds or newtons of strength in the legs, and then as well as the manual muscle testing, just as the hold your leg up, don't let me push you down, which I'm sure you guys have seen countless doctors and therapists do throughout your life. And then I had you guys so kindly take the time to fill out those physical activity questionnaires because I was a little bit concerned that the strength and 6-minute walk test distances that I was seeing wouldn't necessarily be typical, given that we have all the boys and men in Florida in June, not in their typical environments. And then we also looked at the cardiolipin ratio analysis, and Dr. Vernon again reviewed the genotype data. And essentially, to summarize from what she saw from the genotype data, is she compared certain mutations on certain exons of the TAS gene and looked at their relationship with cardiolipin ratio, and she seemed to find a pretty good correlation on that. Some certain genotypes and specific mutations correlated with high cardiolipin ratios, and some certain mutations correlated with lower cardiolipin ratios. So we're definitely looking at that more longitudinally in our clinic, and then she's hoping to also look at the data from this clinic too to see if that really holds up. So thank you guys so much again for your participation in our studies. We saw the slide yesterday, so essentially what we saw is that the boys and men performed generally lower than normative values on the 6-minute walk test, and we had one young man who performed within the normal range. On average, they were about 4 standard deviations below normal values. And the way we predicted these normal values is there's equations in the literature that take into account age and height, given we know that the delayed onset of puberty in our men with Barr syndrome, so that wasn't necessarily skewed by age. So these normative values were calculated based on height and age. Another thing you guys can remember, I was asking those questionnaires, how tired do you feel right now? How hard is it to breathe at both the beginning and the end of the 6-minute walk test? The biggest thing that we saw is that there was, of course, the boys, and some of them I feel like the younger guys might not have understood the questionnaires fully, so interpret this a little bit lightly for our young men, but the most statistically significant finding that we saw was at baseline, our adults reported a lot more fatigue than the boys. And I also certainly feel that this could have been influenced by the time of day that I saw them, since I don't know if you guys remember, I was kind of scheduled all day from like 8 to 5, so I certainly feel that early morning, nobody was really awake, whether it was the young boys were just waking up or the men might have still been going from the night before. And then at the end of the day, a lot of the men were just like, wow, I'm so tired. So again, the time of day could have also had an effect on this. We also, I don't know if you guys remember, I looked at the heart rate and SpO2 as well before and after. We didn't really see any statistically significant findings, and also felt like my pulse ox was kind of given out on me, so the paramedics were so kind as to let me borrow their more reliable pulse ox, so certainly that could be why we didn't really see anything also. And unfortunately, we kind of had the same issue this year. The pulse ox that travels with me isn't as reliable as the one that stays in our clinic. So that could be something to look at. I could get you guys better data in the future. We also looked at correlation between height and weight. In a general population, there is a negative correlation between weight and 6-minute walk test distance. So the heavier you are, generally the less far you walk, and that was apparent in our boys and men with Barr syndrome as well. Interestingly, in a general population, height has a positive correlation with 6-minute walk test distance, which makes sense. Generally, the taller you are, you could have a bigger step length. But interestingly, you see that same statistic held true in our boys, but in our adults, there was it's a very small, but small negative correlation between height and distance walked. Oh, and I didn't explain to you guys why. I'm saying obviously adults are 18 and above, but here in the study I divided it 4 to 19 and then 20 and above. The reason for that is that in the literature, there's a normative value for 6-minute walk test distance for ages 3 to 19, and then there's also a strength value for adults that's 20 and up. So that's why I do have this one 19-year-old subject who I've grouped in with the pediatrics as opposed to the adults, if you were wondering that. I do know that when you're 18, you are an adult. So in here, what we're looking at is comparing the pediatrics that we saw with the men, comparing the values that they walked on the 6-minute walk test to normative values. And again, these normative values we got from using equations in articles that were provided that took into account height and age. Interestingly here, the boys walked about 62% of the predicted value, and our adults walked about 40%. Another interesting thing, and you guys might see this through just watching the boys grow into men and the activities they do, is when I was doing the 6-minute walk test, I felt like a lot of the boys, they generally walked farther than the men, but the boys would walk and take a rest break, walk, take a rest break, whereas the adults generally, they just walked the whole time without taking a rest break, but certainly a slower pace. So perhaps thinking our adults have learned activity pacing and our boys are still learning that. This is also, you guys saw the slide yesterday for those of you who kindly listened to me act like I was Dr. Vernon. When we're looking here, we see that the knee extensors, so knee extensors are big quads here, hip flexors, muscles that do this, and our hip abductors, muscles on the side of our butt that do this, are significantly weaker than normative values in the literature. And interestingly to me, because when I've seen some of you guys who are so kind enough to join us at our clinic, when I originally just started doing the manual muscle testing in our clinic, I thought that the muscles that I assessed were the weakest were these hip abductors that go like this and your hip extensors, which are your big butt muscles there. But when comparing this, actually, if you just look at the percentages, the knee extensors are the weakest. And I was generally perceiving those as pretty good in comparison to my other muscle groups. So I think the handheld dynamometry does help us learn a bit more than the manual muscle testing, but I think it makes total sense, especially with some of the difficulties that our adults report with in the future. For example, going up and down stairs, you certainly need a great amount of knee extensor strength to do that, as well as getting up from the floor is quite challenging for some of our adults. So certainly lets me think, I think it would be nice if we could target some knee extensor strengthening that could possibly help improve function in our older men. Here, this is just normalizing the force that I got, so just dividing the force of one muscle group that I assessed for body weight, and you can see those same trends hold up. Interestingly, when we compare, so next thing I looked at is just the average pediatric strength, and these values are newtons, I'm sorry. I assess them in pounds because that's what I understand, not newtons, but then all the normative values are newtons, so I converted the pounds to newtons. So these are values in newtons, and if you just look at it, you think, the adults are stronger than the boys. That makes total sense because generally adults are stronger than boys. But if we so just divide those values by their body weight, actually the boys are a lot stronger than our adult men. And I don't really have a great reason for that. I think it's a couple. I think possibly, obviously a cumulative disease process that's happening with Barr syndrome, and then I think just A lot of the boys I've seen are kind of more active than some of our adult men, so I think just kind of a sedentary lifestyle and just overall weakness and deconditioning from not moving, in addition to kind of the barth muscle deconditioning. And then also possibly just an early onset aging process. So I don't really have a great reason for you guys for this, but I do find it interesting that it was for every single muscle group, and it was statistically, the pediatric population was statistically significantly stronger than the adult. So certainly interested in looking at that more so I can try to have a good reason for you guys for why that is. Next, this is showing you, so the manual muscle testing was the put your leg up, don't let me push it down, which I'm sure you guys have seen doctors and therapists do all the time. And then the handheld dynamometry was when I used the dynamometer, it gave me the force reading. So here you can see that, for example, for a muscle group if I just graded it 5, meaning that, they kicked their leg out and I couldn't break it, so I graded you a 5. There is such a wide variety of handheld dynamometry scores for that, so it's just showing me like, probably not getting the best information that I could doing the manual muscle testing in my clinic, so that's why I feel that it's more beneficial to do the handheld dynamometry, because it actually gives us a quantitative number that we can look at over time. And while it takes a tad bit longer, which some of you guys have come see me know to do the handheld dynamometry than the manual muscle testing, I do think it's really valuable. Next, I was interested in looking at correlation between strength and 6-minute walk test distance of certain muscle groups, thinking, oh man, if I see this huge correlation, maybe if we target strengthening of this one muscle group, because I know that as great as our boys and men are, I don't feel that most people have done the exercises that I prescribed when I see them in our clinic. So I'm thinking maybe if I can just say, if you can strengthen this one muscle group, it will really help. Unfortunately, I didn't see a super strong correlation between any muscle group, because in other diseases that have been studied, for example, Becker muscular dystrophy, they found a really strong correlation between knee flexor strength and timed walk test distances. So I was hoping to be able to give you guys something amazing like that, but unfortunately, just minor positive correlation, so certainly something to look at in the future, but the higher correlations were between the knee extensors, knee flexors, and hip flexors, but certainly not a super strong correlation there. So there goes my being able to encourage people to perform one exercise to improve themselves theory. Next, the physical activity questionnaires, I actually learned a lot from them. You guys turned back 16 to me. Unfortunately, I didn't analyze 2 of them because I couldn't read them, but I think I could read all the ones this year, so we're off to a more positive start there. The nice thing about the physical activity questionnaire, for those of you who completed it, for the boys who are under 14, is it asks about what types of activities they like to do and when they're performing those activities. So what I learned, and then also you can take those scores that you guys put, which were kind of like sometimes, always, never. They have a formula where I can calculate an activity score from 1 to 5, 1 being low physical activity and 5 being high physical activity. So we found an average of 2.41 in the 14 questionnaires that I could score, and that indicates a low to moderate level of physical activity. We also found a moderate correlation between that score and the 6-minute walk test distance. So that lets me know that even though I saw these boys in June in Florida, not in their typical environment, what I assess is probably somewhat indicative of how they're functioning when they're at home with you guys. Another interesting thing is most of the activities reported most frequently by the boys were tag, swimming, and walking. So I'd also be interested to see if I had you guys do those for me in the winter, because I imagine most of the boys aren't participating in swimming as frequently in the winter. Another interesting thing was most of the boys were most active during PE and recess and right after school and on the weekends. They weren't as active in their spare time, because I know they love video games. That was like our first answer in the physio session yesterday. What do you think of when you think of activity? Video games. Good, but a little bit more movement might be nice. So that kind of was shocking to me, because I feel like a lot of times some of you guys have reported to me that the boys are so tired after school, but on these questionnaires, it was reported that they were most active right after school or on the weekends. And the weekends kind of made sense to me, but the right after school didn't so much. So I'm interested to see what the questionnaires tell me this time. For our adults, they completed a different questionnaire, and this looked at kind of exactly MET minutes, which are just like intensity of activity and duration that you do it per week. This was interesting to me. So I got 17 back, and I excluded 1 because 1 gentleman had been traveling for several weeks before, and it asked you to recall what you did the week before. So I analyzed 16 of these. And based on the reports that you guys give me, I can score it and put you in an activity level of low, moderate to high. Now, I feel like I know most of these men and kind of their lifestyle, so I feel like the 7 subjects that reported a high physical activity level was a little bit of embellishment. I feel like perhaps that, I don't know how, I feel a little bit more confident about my pediatric data. But I also did see a strong, one question on this questionnaire specifically, how many days a week do you spend walking? And we did see a positive correlation between that and the 6-minute walk test distance. So again, I have some confidence that what data I collected here is similar to them in their home environment. Another interesting thing that I like about the International Physical Activity Questionnaire that I had our men 15 and older fill out was it asked you to say the average amount of time you spend sitting per day. Our adult males spend an average time of 5.5 hours sitting per day, and interestingly enough, we found a small negative correlation between the amount of time spent sitting per day and the 6-minute walk test distance. So the longer they sat, the shorter they walked. So maybe I can use that in combination with some of our other data to encourage more physical activity and exercise. So I found that really interesting too. We also tried to look at correlation between 6-minute walk test and cardiac function. We saw none. I will say here, the reason, if you guys remember, I saw 34 of you guys for the strength and 6-minute walk test. Only 29 of those who I saw got echoes, and we did exclude patients who had transplants from the echo, since they were just, Dr. Reed Thompson was just interested in looking at patients who had the Barr syndrome heart. So yeah, we saw no correlation between that, which isn't uncommon in other populations. There's been very little correlation between echo variables and any type of physical function. As I stated yesterday, Dr. Vernon found a very strong correlation between the 6-minute walk test distance and cardiolipin. So it was inverse. So the higher someone's cardiolipin was, the shorter they walked on the 6-minute walk test distance. So we're really interested in looking at this in the future because the reason, unfortunately, we can only do cardiolipin testing right now in the United States as part of a research as opposed to with your general clinic visits is because it's not covered by insurance and it's quite expensive. And I don't know if you remember me saying Dr. Vernon sends these to Frederick Voss in Amsterdam. So there's nobody great that does it in the US. So the really exciting thing for us about this is we're hoping that it holds up with the clinic that we have right now and also the clinic that we performed at this conference, because then a 6-minute walk test distance is, easy to get, costs virtually no money to perform. So that would be something nice in the future if we can use that to kind of track progression or improvement as opposed to, unfortunately, only being able to do the cardiolipin at this point through research in the United States. So some limitations, certainly. This was a single-time observation. As I stated earlier, this was certainly an atypical environment as most of us don't live in Florida. And then, like I said before, I think the strength and functional exercise capacity could have been limited by the time of day that I saw, especially our older gentlemen, and then we didn't have any controls. But I am excited this year, and I'm so thankful for the brothers and the cousins and the friends that participated because we did see controls this year. So I'm interested to share that data with you guys when we have it. So in conclusion, I think that the 6-minute walk test provides useful information regarding functional capacity and should be monitored over time. Lower extremity strength should definitely be performed via handheld dynamometry if possible, because I think it's a lot more sensitive than the manual muscle testing. And it's important for us to monitor self-reported physical activity and see if it changes in response to an intervention you guys are participating in, whether that's a physical therapy intervention or some type of drug intervention or something like that. So thank you guys for listening to me again for Dr. Vernon. Do you guys have any questions? Yeah.
I'm wondering the difference between the older and the younger guys. It seems like it takes them a long time to recover from any activity.
Oh, sorry.
So it seems like it takes our guys a long time to recover from one activity to the next.
Mm-hmm.
Is there any thought that maybe, especially in the older guys, if their walk distances were poor, that maybe they exerted themselves a lot when they were doing the muscle test and they didn't have enough rest time in the 10 minutes?
That's a really good question. Definitely so. The the reason we did the 10-minute break before is because the American Thoracic Society recommends that to standardize, and this was originally developed by the American Thoracic Society for patients with pulmonary issues. So that's why we go off those guidelines. So that's what they recommend, but that's a really great point as well.
And maybe one second question about, will you do comparisons of the same subjects this time from last time to see if those individuals have a progression?
Yes, we definitely want to. I believe Dr. Vernon just has to check with our IRB, like those consents you guys signed for us to kind of, because for all this data, we de-identified it when we had the clinic. So yes, we can. We just have to double check the regulatory issues behind de-identifying the data from our previous clinic. But that's what we're certainly interested in.
Regarding the 6-minute walk test, I wasn't in there when both my boys did the walk test, and one was a control and the other wasn't. And I was just wondering what you asked them to do, because Josh was, thought it was a competition, and so he, moved quite swiftly. And I don't think Jake had that same thought in mind when he did it. So I think he just kind of la-la'd himself around. So I think that maybe that, when they have a different expectation about what they're supposed to be doing, that would skew how they were.
I definitely, yeah. So with that, you're supposed to, we try to keep a script as standardized as possible. Essentially, the instructions are, the goal is to walk as far as you can in 6 minutes. The only rule is no running. So that's kind of what we say. But I do agree with you. I saw a lot of boys coming and being like, how many, he walked 15 laps. I'm going to try to walk 17 laps. So I do agree that some of the boys had a different kind of mentality, and it was more of a competition for some, and that certainly could skew our results.
Well, I just tend to think that sometimes with the boys that have Barth, our expectation is lower for them, and therefore they don't perform as best that they can.
Yeah.
And I think that tends to be a problem for a lot of things that they do. So.
Yeah. No, that's a really good point. Yeah, and it would be really interesting to see. It would be tough to do because there's also kind of like a learning effect with the 6-minute walk test. Say, essentially, if you do it once, most people, if you do it the same day, would probably perform better because they kind of know how long. But it would be interesting to kind of compare if we did more of like an encouragement kind of script versus just, please try to walk as far as you can in 6 minutes without running. It would be interesting to see because I would imagine we would see a difference. So I don't know how we would kind of set up that study, but that's a really great point. And I think, I agree with you. If you have kind of low expectations, you're going to have low performance. So yeah, I agree. That's something that we need to think about as families and clinicians, just our expectations, and also just the way we're communicating those expectations could have different effects. I agree. If someone kind of communicated to me like, oh, Brittany, I don't think you're going to do well here, I probably would feel pretty poorly and not excited to participate. So I agree. Great point.
Good morning.
Good morning.
Is the 6-minute walk test, is that something that is used as a measuring tool in other areas of medicine as well? Or is that something that was developed specifically just for this group? How did you arrive at 6? Why is it not 7 or 5?
That's a great question. So the 6-minute walk test has been around since like the 1960s. It was originally developed for patients with pulmonary disease, so adults with pulmonary disease. It then progressed into being studied a lot in adults with cardiovascular issues. Now it's kind of progressed to being studied in patients with muscular dystrophy, patients with spina bifida, and patients with cerebral palsy. That's a great question how they arrived at 6. There's also a 2-minute walk test that is available that most people say correlates pretty well with the 6-minute walk test that is done in some other populations. So that was kind of where it started, and the way I thought about assessing it was, this is kind of something that's been around for a while. It's well validated in adults and some children, and we do it in our clinic. We were taught it in school, but I agree with you. I don't know why 6 is a magic number, and I just know it was originally developed for cardiopulmonary, like pulmonary disease, and they progress it from there.
So we heard yesterday that the stealth group, I think, was going to try and use the 6-minute walk test as a gauge of some of the success or non-success of that study. Mm-hmm. So if we were to give those results to the FDA, for instance, they saw that that wouldn't be the first time that they had seen a 6-minute walk test as a gauge or something like that. It's not
Correct.
new or, okay.
Correct. It's very common, and I know right now at Kennedy Krieger we have a drug trial for muscular dystrophy, and that's one of the primary endpoints. So it's well used, to my knowledge, in other, like in pharmaceutical trials as well as in general physical therapy and also cardiac medicine.
Thanks.
I talked to Matt Toth about this yesterday because just with the data that he showed in the clinic session that we actually had for the 6-minute walk test, it did show, or I think his point was that the progression of illness gets worse as our birth boys get older. But I don't know if I just maybe took it wrong, but it kind of bothered me in a way. With this really being the only data that we have and the one time that we have the data for that to be, how accurate was that? Because I guess like with Julie's point, maybe, well, and even Aldo yesterday in that session stated that he potentially didn't do his best. So I don't know. It just bothered me. I just wanted to throw that comment out. Whether if it was accurate, and it bothers me in a way, particularly with me having an older, my 19-year-old, you know. I just, will they look at that, just that one data, or do we need to have another year's worth of data before we go forward with proving a point?
Yeah,
That progression is worse in the older boys. I don't know.
Yeah, that's a really great concern. Generally, if you were to do, like, for example, I know Mr. Woodward just brought up about the stealth trial. Certainly with all that, they obviously look at this saying, oh, this has been done in patients with Barr syndrome, but they would certainly do their own baseline. So it wouldn't be like they would just say, oh, he did this. And also they wouldn't be able to link the data from our article to any particular person because it's all de-identified. But I agree with you. The one, I guess, concern with that when you're saying, you know, it does get worse as they get older, then the question is like, well, if you do something and it doesn't show improvement, is it because what you did didn't work, or is it because they're just getting older so they were not going to perform better on the 6-minute walk test anyways? Is that your point, or am I misunderstanding? I'm sorry.
Well, I think my point is that I know that's the only data we have, and that's what it looks like it has happened. And it may be true. It may be a true information, but it may not be, because I don't know if our boys understood enough about what it really meant before they did it. You see what my point is?
Oh, I
so
totally
I just
understand.
think it might have been an unfair statement or perception that maybe the boys are getting worse. I don't know. It just kind of hit me just a little wrong.
No,
I just think it might be skewed a little, and I think if we are going to use that data, that 6-minute walk test, that maybe prior to them doing it, they really need to understand that this is a serious piece of information and that they really do need to do their best. And not to say that they didn't do their best, but
no, I totally understand, and I agree with you 110%. Just looking at something one point in time, not following it over time, clearly, that's just us speculating that it declines over time because we looked at younger boys versus older boys, but we certainly didn't follow one boy. So that's why that's why we are interested in looking at that data. We did it again this clinic, and then I also do it in the quarterly clinics that I have at Baltimore to see, does this really hold up over time? Because I agree with you. These correlations and stuff could be true, but they also could not hold up. So I'm hoping with more data. And also, you guys bring up very good points, like perhaps we should modify the instructions before. The instructions that I provided were just to be standardized according to the American Thoracic Society guidelines. But I agree with you, perhaps if we were to provide a little bit more education about it before, that could certainly affect the outcome. So that's really great feedback. Thank you. And you bring up a great point about the location. Unfortunately, yeah, I agree. Especially on Tuesday, it was really crazy in there. So it might be nice for us. Unfortunately, I wish there was a room where we were just performing it, and that would be standardized. According to American Thoracic Society guidelines, you're supposed to do it on a non-carpeted floor with a 100-foot walkway. The length of these rooms is only 50 feet. So those are both great things to take into account, and certainly I'll try to modify it to be more standardized and think about like a way that we can standardize in a standardized manner, provide that education to all of the boys before performing it. Thank you so much.
Brittany, I wanted to ask you, I wasn't in the session, but did you give the boys their results? Or did they know how they did? Or can we get that information so that if they have tests somewhere else that we can kind of track it ourselves?
So they didn't, so the way it does is you count how many laps they did and then you score it because you times the amount of laps by the 30 meters. So I know Lucy helped with the administration. If boys asked, she would tell them how many laps they walked, but we didn't specifically tell them the distance they walked. Yeah, they knew it all. It was a hot competition out here. The one thing is I'll have to check with Hillary and the IRB because for our regulatory stuff, we said we're going to de-identify the data. So I don't know I know from some of you who read our paper from last year, most of you kind of said you knew who you were on there, even though the data is de-identified. So I'll have to check with Hillary about, I don't think I'm allowed to, for the data that I collected at my clinic, since that's in a medical record and someone could access it, that could certainly be used by other people, but I don't know for certain that from a regulatory standpoint, I could give out the data that I collected here. But that's a great question, and I'll check with Dr. Vernon about that.
I think we're done.
Thank you, guys.
Thanks.